Thank you for joining our long Lyme immune responses and diagnosis and treatment efficacy of Lyme disease today. My name is Adina Berkowitz, and I am the Executive Director of LymeTV. Also online assisting me from our team is Jan Zelener, our Director of Science. Please feel free to type in the chat box your name, where you're located, and your institutional affiliation as a few more people are joining us. All right. For the sake of time, we will get started. Next slide, please. This activity is funded by the Health Resources and Services Administration, or HRSA, of the U.S. Department of Health and Human Services as part of the award of Model State-Supported AHEC programs. Next slide, please. Continuing education credit is available for this activity through the University of New England College of Osteopathic Medicine, UNECOM. Please email info@LymeTV for CME credit. Next slide, please. Our partners for this event are the University of New England and Maine AHEC, which is Area Health Education Centers, and the University of New England Center for Osteopathic Medicine, Department of CME, is a joint sponsor. Next slide, please. Although this slide is for webinar features, we are actually today in meeting mode since we are using UNE Zoom. However, standard webinar housekeeping rules apply. Please remain muted throughout the event. The webinar is being recorded. Please be respectful in the chat, and live transcript is available if needed. Please type any questions in the chat box, and one of LymeTV's team members will assist. Next slide, please. We are very excited to have with us today Dr. Monica Embers to discuss her outstanding research. Dr. Embers is currently an associate professor in the Division of Immunology, head of the Education and Training Program, and the director of Vector-borne disease research at the Tulane National Primate Research Center. Her research program regarding Lyme disease and its infectious cause, Borrelia burgdorferi, specializes in animal models. The research is centered around four major efforts: identifying treatments that can eradicate the infection, the Borrelia burgdorferi infection, detection of persistent Lyme disease spirochetes in human autopsy tissues, immunodiagnosis for B. burgdorferi infection and cure, and prevention of Lyme and tick-borne diseases through vaccination. Next slide, please.
All right, thank you, Adina. I guess I'll go ahead and get started, and while you fill out your poll. My name is Monica Embers. I'm here today to talk to you about the impact of immune responses on the successful diagnosis and treatment of Lyme disease. So our learning objectives for today are first to summarize the challenges to diagnosing Lyme disease at different phases, to recognize the ability of Borrelia burgdorferi to suppress immune responses and how this can affect serodiagnosis, which is how we diagnose Lyme disease today. Third, to examine the evidence for post-antibiotic persistence by the Lyme disease bacteria. And finally, to explore the role of immunity in treatment efficacy and the curative potential for combination antibiotic therapy. So I do not have any financial arrangements or affiliations with commercial entities whose products may be discussed in the materials. So let's talk about spirochetes in general. So these are a diverse group of bacteria. They're commensal some are commensal in the guts of arthropods, and some are obligate parasites of vertebrates. Among the pathogenic spirochetes are the Borrelia, the treponemes, which cause syphilis and periodontitis, and the leptospires, which cause leptospirosis. Compared to other bacteria, who might have one or two plasmids, which are extra chromosomal elements. Borrelia can have up to 21 different plasmids. Some are indispensable. They can be linear or circular pieces of DNA. Compared to other bacteria, they also encode a large variety of lipoproteins. And we think that this is for the primary purpose of evading the host immune response. In fact, it has been shown that there is a characteristic downregulation or diminution of lipoprotein expression, which is concurrent with the host antibody response. And so here you can see the spirochetes under dark field microscopy moving in the media. Lyme borreliosis itself is sort of a multi-stage disease. It's transmitted by Ixodes ticks. Oftentimes, the nymphal ticks are responsible for transmission in most cases because they're out questing at the height of human activity, although adult ticks can also transmit. In the first stage of illness, there is characteristic bullseye rash or erythema migrans. It's important to note that this can be highly variable. It doesn't always appear the same on every person. It could depend on what site of the tick bite. It could also depend on the sex. We've seen that there are sex differences, people with dark colored skin, and also some people may not develop it, or it will not be seen if you have like a bite on the scalp of someone with long hair. So it's important that this is pathognomonic, but it's not consistently seen in every patient. And then it follows with sort of nonspecific symptoms like headache, fatigue, malaise. After the spirochetes disseminate into the tissues, you can oftentimes see facial palsy or Bell's palsy, cardiac manifestations, and you start to see neurological manifestations. The most common being meningoencephalitis and cranial neuritis. And then the final late stage in the US, we see in about 10% of patients chronic destructive arthritis. The European strains can cause acrodermatitis atrophicans, which is a multiple erythema migrans lesions, and then of course neuropathy and cognitive impairment, which is called neuroborreliosis. So a little bit in terms of the history, early in the 20th century, there were physicians in Europe who postulated that the erythema migrans rash that they were observing could be caused by the bite of ticks and caused by a tick-borne bacterium. But it wasn't until the early 70s that we really characterized this in the United States. And here, physicians observed clusters of children with arthritis in and around Lyme, Connecticut. A rheumatologist by the name of Alan Steer characterized these patients and postulated that it was caused by a tick-borne infection. And later in the early 80s, spirochetes were identified in the midgut of the adult deer tick and given the name Borrelia burgdorferi after their discoverer, Willie Burgdorfer at the Rocky Mountain Labs in Montana. And so finally, conclusive evidence came when the spirochetes that cause Lyme disease were cultured from patients who had the EM rash. So we know that Borrelia burgdorferi persists in both reservoir and incidental hosts. So rodents are what we call reservoir hosts. The spirochetes utilize a variety of different reservoir hosts, from small mammals to birds. Paramiscus leucopus is the most common. And these rodents fail to clear the infection with Borrelia burgdorferi. So survival of the pathogen through the enzootic cycle requires the ability of those spirochetes to proliferate with minimal host immunity. And so primates are incidental hosts, and they appear to harbor a low-level infection. And the immune evasion tactics by the spirochetes contribute to persistence in the incidental hosts as well. So not only do Borrelia spirochetes evade host immunity, but they actually suppress host immunity. And so these are some mechanisms by which Borrelia burgdorferi can affect the immune response. They engage in antigenic variation with a variable surface protein, which contributes to immune evasion, as does the change in lipoproteins. They can become physically secluded. They're found in joints and cartilaginous tissues. In terms of adaptive immune suppression, they can induce anti-inflammatory cytokines, which I'll expand upon. They can inhibit complement, so they inhibit the complement cascade, and they can also tolerize monocytes. So we have to realize that immune suppression of the host is done by the spirochetes, but it's also done by the ticks that transmit them. In this paper here, you'll see that macrophages and dendritic cells from wild type and IL-10, interleukin-10 deficient mice were stimulated with Borrelia burgdorferi. And IL-10 is anti-inflammatory, so it's an immunosuppressive cytokine. So in wild type mice, both cell types increase the production of IL-10 with concomitant suppression of inflammatory cytokines IL-6, IL-12, and TNF. However, in the IL-10 deficient mice, those cytokines were elevated in both monocytes and dendritic cells. So this is a really important role that Borrelia plays in controlling the immune and inflammatory response. So in terms of the ticks that transmit them, we know that tick saliva suppresses antigen-presenting cells and lymphocytes. So if you think about it, and there are a lot of different mechanisms shown here, if you think about it, the Lyme disease vaccines and the anti-tick vaccines have to overcome the immune suppression that is imparted by the tick saliva as well. So today I'm going to talk about how Borrelia burgdorferi affecting the immune response can be detrimental to both diagnosis and treatment of Lyme disease. So the CDC case definition of Lyme disease can be either the erythema migrans or the presence of at least one late manifestation and laboratory confirmation. So the laboratory criteria for diagnosis includes at least one of the following. The first is isolation of Borrelia burgdorferi, and this is rare because it's blood-borne for a narrow window of time, and it's only accurate in about 10% of cases. Or the demonstration of diagnostic levels of IgM or IgG antibodies to Borrelia burgdorferi. I'm going to show you that this is highly variable between patients. And finally, the significant increase in antibody titer between acute and convalescent serum samples. And again, this is highly variable, and it depends on what antigens are used to look for the antibody response. So I'm going to talk about the variation and suppression of B cell responses. We have evidence both in mice and in primates. So several years ago, we asked the question of how immune responses changed over time and over the course of infection and post-treatment. And so we did a longitudinal assessment of responses to certain diagnostic antigens in non-human primates that were infected over a long period of time. And so what you can see from this graph here is that the antibody responses change over time, and it depends on what antigen you're using to look. So each panel is a different Borrelia burgdorferi protein or antigen. C6 is a peptide derived from a Borrelia protein, outer surface protein C, OPPA2, and DBPA. These are all Borrelia antigens, and you can see that red indicates monkeys that were treated and blue indicates monkeys that were not treated. The treatment period was between weeks 16 and 20 with doxycycline orally. And so with C6, we've known for some time that C6 titers can drop after antibiotic treatment. And we certainly observed this with the treated non-human primates. And the C6 titers in these two animals stayed high throughout the course of infection. We also noted DBPA, the antibody responses to that antigen came up and stayed high throughout the course of infection. Anti-OSP-C, those titers came up early in all of our monkeys and then declined irrespective of treatment. And then OPPA2 antibody titers came up in all animals and they declined, but incompletely in the treated animals. So we thought that this might be an indicator of treatment outcome because these monkeys were found to have a persistent infection after antibiotic treatment. So we use these data with the goal of developing a test that could be used to diagnose Lyme disease at all phases of disease. And so this is just an indication of how the assay works. It's a bead-based assay where fluorescent cytometric beads are coated with the specific antigens, and then the human serum is passed over those beads. All the non-binding events are washed away, and then a secondary antibody coupled to phycoerythrin is used to detect the serum antibodies that are bound, and it gives you the ability to both qualitatively and quantitatively determine the antibody responses to multiple antigens at the same time. So we wanted to know how this looked in another set of animals that were infected by tick bite. So we had 10 animals, 5 were treated at 4 months post-infection with 28 days of oral doxycycline, and 5 were untreated. And again, these were infected by tick bite. And then several months later, we performed xenodiagnosis. And finally, after 12 to 14 months, we performed a necropsy. So what you can see right away is that we have the 5 untreated animals here and the 5 treated animals here. One of our treated animals did not seroconvert. We were unable to detect any antibodies in this animal. And then we have another animal in the untreated group that only seroconverted to 2 of the antigens, and all those responses were gone by later stages of infection. We also looked at C6, which is here in the light blue line. And the thinking is that C6 declines only in after treatment. But we have several animals here, here, and here where you can see that the C6 titers declined in untreated animals. So if that particular ELISA is being used to diagnose these patients at the later stage of disease, it will not work. And I just want to keep your attention on this animal here, IK14, that was seronegative. These are the results from xenodiagnostic ticks. So these are uninfected ticks that fed on the animals that were infected and treated or untreated. And so the thinking is that these uninfected ticks will take up the spirochetes if they're present, and it can be used to diagnose an infection, a persistent infection that is otherwise hard to detect. And so if you look here, we have examples of 3 treated monkeys for which we were able to identify persistent spirochetes from the xenodiagnostic ticks. Shown here, these spirochetes and here are from that animal that was seronegative. So we know that this animal, even though it didn't seroconvert, was persistently infected. These 2 are also from an untreated animal. Then we did RT-PCR, which is for RNA, and RNA should not be produced from dead spirochetes. So what we found was that using 2 different transcripts, we were able to identify our RNA in multiple animals from the xenodiagnostic ticks, whether they were treated or not. So this indicates that the spirochetes that were acquired by xenodiagnosis were still transcriptionally active and or metabolically active and alive. So the next thing we did was histopathology. And so these are 2 different antibodies staining the spirochetes. One is monoclonal, one is polyclonal, and this is the merge of the 2. And what we found in the treated and untreated animals was mild to moderate inflammation in a variety of different tissues. Shown here in D is the cerebrum of a doxycycline-treated animal, and you can see focal expansion of the leptomeninges. Here you see some inflammation in the brainstem of another treated animal. And here in F and in G, we see spirochetes in the parenchymal tissue of 2 animals that were treated with doxycycline. So they're still in the brain of these animals that were treated. We also have staining in and around the peripheral nerves. This is the ulnar nerve from an untreated animal. We saw spirochetes in the heart. This beautifully stained red spirochete is in the heart tissue of that seronegative animal, IK14. Here's an indication of pericarditis and interstitial inflammation. We also saw inflammation in the skeletal muscle with a cross-section of a spirochete shown here. This is in the joints. We saw some adipose tissue and lymphocytoplasmic inflammation, lymphoplasmic inflammation in and around the joint tissues and in the urinary bladder. So what about direct suppression of immune responses? So there have been some novel studies in mice indicating this, and this comes from the Baumgarth lab. And what she did was she did an experiment where she had 2 groups of animals, 2 groups of mice, one infected with Borrelia and one uninfected. And they were given a vaccine antigen for influenza virus, and it's called APR8. And so once the mice were vaccinated, she monitored the serum for flu vaccine specific antibodies. And what you can see from this graph, and I'm just going to highlight panel E here, is that those animals that were Borrelia negative, so did not have a Borrelia infection, generated really good antibody responses to the flu vaccine. And shown here in the dotted line, those are the animals that were infected with Borrelia. And you can see that there are very poor antibody responses generated. And this is quantified here. So this is the uninfected mice, and this is the infected mice. And that's the percentage of antibody secreting cells in those 2 groups of mice. So we know that after Borrelia infection, germinal center responses, which are where the T cells and B cells come together and stimulate and produce antigen-specific responses, they're not induced in the same way they are for other infections. And they basically fall apart very quickly. And we know that there's a lack of long-lived antibody responses and development of memory. So a patient can be infected with Borrelia burgdorferi, and a year later will not be protected from the immune responses generated, and they can become reinfected. So that means that there's no memory response. So what about non-human primates, incidental hosts? So we tested this in our lab as well, and we hypothesized that infection with Borrelia would non-specifically inhibit B cell responses. So we had 9 rhesus macaques that were enrolled. Group 1 was infected only with Borrelia burgdorferi. Group 2 was immunized and infected, and Group 3 was immunized only. And for these studies, we used an HIV-derived GP130 subunit antigen as our vaccine because this had been very well characterized in non-human primates through the HIV research. And again, we performed our infection by tick bite to mimic natural infection. So we looked at antibody levels to both IgM and IgG. We looked at B and T cell populations, and we looked for both functionality, phenotype, and also looking at specificity. And I'm not going to show all of those data, but this is the experimental outline where we do an infection, immunize, a month later we boost, and a month after that we boost again, and then 4 weeks later we have the endpoint. So what I like to point out here is that on the left we have the vaccinated only, and on the right we have the vaccinated plus Borrelia burgdorferi. There are 3 monkeys per group, so each line represents 1 animal. And you can see that by 3 months, all 3 of the vaccinated only animals showed an increase in antibody titer after the second boost. Here, on the vaccinated plus Borrelia group, we had 3 animals again, and one of those 3 animals did not generate antibody responses after the second boost, indicating that there's an impairment of B cell responses. Now, in mice, they all look the same, but those mice are inbred. Non-human primates and humans are highly outbred, so we expect to see huge variation, and we did indeed see that. So we also looked at serology for Borrelia antigens, and each line indicates the response to one of 5 different Borrelia antigens that I described in our multiplex test. And you can see here that we have actually 2 animals that were seronegative for Borrelia. But this animal in particular that was infected was seronegative to those 5 antigens, and we cultured Borrelia from multiple tissues in this animal. And we pre-screened all of these to make sure that they didn't have any Borrelia infection. And so this appears to be a seronegative animal that was infected. So what are the correlations between antibody responses and treatment outcome? So we're going to look at differences in antibody responses among early Lyme patients and in response to treatment. And then we're going to look at some data regarding plasmablasts in cured patients versus those who develop post-treatment Lyme. So post-treatment Lyme disease is the continuation of symptoms after standard antibiotic therapy. And there are multiple potential causes, including the induction of inflammatory responses by dead spirochetes or spirochetal antigen. We know that the peptidoglycan, for example, of Borrelia can induce inflammatory responses on its own. The second is continuation of active spirochetal infection, which I've demonstrated several times in non-human primates and showed you some of those data. And then finally, irreversible sequelae from a previous active infection, which would indicate an autoimmune etiology. And to some extent, I think all 3 of these play a role. So we looked at the antibody responses in 2 cohorts of patients. The first was a panel of CDC Lyme patients that were very well characterized, and we compared that to the C6 ELISA, which is another test that's used. And then the second cohort of patients are those who either were cured after treatment, had some residual disease, or were characterized as having post-treatment Lyme disease. And so these are all patients who were diagnosed early with a physician described erythema migrans rash. They were all given the same course of doxycycline. And out of those, 61% of patients were clinically cured, 25% had clinical symptoms only, 3% had functional decline only, and this 11% here are those who have post-treatment Lyme disease characterized by clinical symptoms and functional decline. And these are patients that came out of the SLICE study in Dr. Alcott's lab at Johns Hopkins. So what I'm showing you here is simply the results of the 5-antigen test with patients who have Lyme disease from the CDC panel, shown here in bold. ELC is early Lyme convalescent. LA is Lyme arthritis. And you can see that the Lyme arthritis patients have the highest antibody responses. And this one in particular responded to all of these 4 antigens that we tested to a very high extent. And we use that as a comparator. That's why I'm pointing that out. We also tested against lookalike diseases like syphilis and mononucleosis, and healthy endemic and healthy non-endemic controls. And what we found was that just adding these 5 antigens that we originally characterized, we increased the sensitivity to 79.5%. compared to what's commonly used, the 2-tier test, which is 61.4% sensitive. And these patients are already very well characterized. So you would think that the sensitivity should be very high. In comparison to C6, which was 77%, we still have very high specificity. But it just shows that we need to look more broadly at antibody responses in order to identify all patients at all phases of disease. So then we have the 3 sets of patients. We have the clinically cured, we have the residual, less severe symptomatology patients, and then we have the post-treatment Lyme disease patients. And originally, I thought that patients who develop post-treatment Lyme disease would have a persistent infection and would have lingering persistent antibody responses that we could detect. But instead, what we found is that those patients who develop post-treatment Lyme disease have very poor antibody responses to begin with. If you look at the clinically cured patients, here are their responses to multiple antigens compared to that Lyme arthritis patient. And you can see that they generated, those that returned to health generated strong antibody responses to 2 or more antigens in our assay. Whereas all the patients characterized as having post-treatment Lyme disease either showed weak responses to all antigens or produced a response to the OPPA2 antigen that did not decline. So if you look at this in a different way, you can see the top are the healthy, here in the middle are the residual less severe, and the bottom are the post-treatment Lyme disease patients. And you can see their responses to 3 different antigens. Clearly, the post-treatment Lyme disease patients have very poor antibody responses to the infection. This was also reiterated in a study out of Bill Robinson's lab at Stanford. And what you can see here, these are the plasmablasts or antibody secreting B cells in the untreated 1 month, 6 months, and 2 years of these cohorts of patients. So those who return to health are in blue, and those who develop persistent disease are in purple here. So you can see that the patients who returned to health had increased clonal expansion of B cells from the beginning of the infection compared to those who developed post-treatment Lyme disease. So it appears that host antibody responses are predictive of clinical cure. And this is probably related to the fact that the antibiotics we use, doxycycline and amoxicillin in particular, don't kill the pathogen. They rely on a good immune response to cure the infection. And we've seen that Borrelia can suppress the immune response. and that patients who develop post-treatment Lyme disease have poor immune responses. So in terms of antibiotic efficacy against Borrelia, we've shown that the development of persister cells like Borrelia that persist in the presence of antibiotic, these have been performed in vitro and they're associated with slow growth. And this is what Borrelia does in the host. All determinations of the minimum inhibitory concentration or the amount of antibiotic that we need are done in vitro or in the test tube, despite the fact that inside the host, the phenotype and the growth of the bacteria can be very different. And we've actually shown that when the bacteria are host adapted, they are much more tolerant of the antibiotics that we're using. So I've shown you that the Lyme disease bacteria persist in animals, but what about humans? So I'm going to present to you 2 cases that we've published, and this comes from autopsy specimens of human cases. And the first is a woman who contracted Lyme disease at age 54 with a well-characterized EM rash. She was given doxycycline, and this led to symptom resolution. However, 2 to 4 years later, without any known subsequent tick bite or infection, she developed a sleep disorder and cognitive problems, and these gradually worsened. She had deficits in multiple executive functions with neurocognitive testing. She was then treated with IV ceftriaxone at age 60 for 8 weeks, and this led to about 60% improvement in her neurological disease. And then she was given oral amoxicillin for 6 months after the IV treatment. Eventually, she developed severe oral dystonia and was unable to eat and died 15 years after the initial infection. So what was determined from both her pathology and her clinical manifestations was that she had a clinical diagnosis of dementia with Lewy bodies. And when we got her tissues, we were able to identify by both PCR, DNA in the brain, and by immunofluorescent staining, persistent Borrelia in her brain and spinal cord. And these are images. This is the spinal cord, and these 3 images are Borrelia in her brain tissue. And as we continue to section this, we continue to find persistent spirochetes. The next is a report that we just published. And this is the story of a young man who had multiple tick bites throughout his life, was treated with doxycycline a few times after tick bites, but never extensively treated. He then turned to, he developed mental health disorders, anxiety, social anxiety, depression, and then became addicted to substances. Like he started to test different substances, and he found that PCP seemed to alleviate his symptoms. And so we present a case here of mental health disorder with substance abuse. And unfortunately, this led to a homicide-suicide event. The patient went into a psychosis and stabbed his best friend next door and tried to kill his best friend's parents and harmed them, and then killed himself. And so this is a very tragic story of mental health and substance abuse after tick-borne disease. And so what we want to convey is that providers should consider borreliosis as a contributor to mental health disorders, especially if they appear rapidly, have rapid onset in endemic areas. And if this is noted, it could reduce morbidity and mortality, and if it's adequately treated. So for this patient in particular, we were able to identify spirochetes in the heart and the pancreas. And so shown here in green and here in red, you can see the spirochetes in the heart in the top panel and in the pancreas in the bottom panel that were identified from the autopsy tissue. We also identified quinolinic acid in the brain, which is produced but should not accumulate. And this is correlated with mental health disorders. And basically, it's the result of disruptions in the tryptophan kynurenine biochemical pathway that lead to the production of quinolinic acid, which is neurotoxic. And again, back to the PCP, this is an NMDA receptor antagonist. And Borrelia burgdorferi can induce this through the kynurenine and quinolinic acid pathway. So it's no wonder that he found something that could antagonize the NMDA receptor to alleviate his symptoms. So in terms of the conclusions on Borrelia persistens, our studies here in animal models and autopsy specimens indicate that the Lyme disease spirochete can persist after conventional antibiotic treatment. We expect a portion of the patients to have a Borrelia infection, but certainly not the majority. And so it's important to consider how Borrelia infection can affect mental health, can affect all kinds of neurological disorders, especially in endemic areas. So how do we combat this? So our strategy going forward in terms of treatment is the idea of combination therapy. And this is how we treat another slow-growing bacteria, which is a hallmark is Mycobacterium tuberculosis. So by combining antimicrobials which utilize different mechanisms to kill or inhibit the growth of bacteria, we believe that we can eliminate persisters. And another researcher who is at Johns Hopkins, Ying Zhang, who studied TB, also identified a number of different combinations of antibiotics from FDA-approved antibiotics that could eliminate Borrelia infection in vitro or in the test tube. So our job was to test these in an animal model. And so we had two different collaborations or two different studies with the same goal of looking to determine if we can eliminate the infection with combination therapy versus single antibiotics. And these are the study outlines, and I think I just want to illustrate a couple of important points. One is that all of our treatment regimens consisted of a 30-day or less treatment, and it was very important for us to wait till multiple time points after infection to determine if the spirochetes regrew. So we didn't just euthanize the animals right after the end of antibiotic treatment because they would have probably been negative. So in the first study, we have the 6-week post-antibiotic time point, and we have a 10 to 11 month post-antibiotic. And in the second one, we have 2 months after antibiotic treatment, where we analyze by multiple methods to determine if there are persisters. And to date, we've tested over 17 different drugs, both singly and in combination. And these data here just are an example of some of the things that we found. And you can see here that cefuroxime, for example, in the xenodiagnostic tick cultures and in the necropsy tissue cultures, on its own did not eliminate the infection, whether it was 6 weeks post-treatment or 10 to 11 months post-treatment. However, certain combinations were able to eliminate the infection, and daptomycin in combination with anything on its own or in combination was also effective. So we also did more extensive analysis, not just culture, but also PCR. And I'm showing here two combinations that were able to eliminate the detection of any spirochetes in all of the mice by PCR or by culture. One is cefuroxime, clofazimine, and doxycycline, and one was cefuroxime, doxycycline, and pyrazinamide. Pyrazinamide is used for persisters and tuberculosis treatment. So we know that it's possible. And we also know that there have been a number of drugs that are repurposed that have been used. And so we have another study where we included repurposed drugs like disulfiram and loratadine in the analysis. And what we found, if you look at this table, is that we have the culture of the tissues or the culture of xenodiagnostic ticks from these mice, 5 mice per group, and none of the single antibiotics were able to clear the infection in this study. However, when we combined antibiotics, we had several different combinations. We found 4 dual combinations and 3 triple combinations that were able to eradicate persistent Borrelia infections. And so these results suggest that combination therapy should be investigated in preclinical studies for treating human Lyme disease. And this was published in Frontiers in Microbiology last year. So in conclusion, doxycycline and cefuroxime, among other antibiotics tested, do not clear the established infection. Certain combinations show promise for their ability to eradicate the spirochetes, and clinical trials with combination therapy for Lyme is warranted. So what about human studies? So there have been a couple of, not many, but a few clinical trials in humans. And the first and most cited are probably the Klempner studies, where the patients received either IV ceftriaxone for 30 days, followed by oral doxycycline for 60 days, or matching intravenous and oral placebos. And the conclusion that the researchers made from this study was that treatment with IV and oral antibiotics for 90 days did not improve symptoms more than placebo. Again, these are single antibiotics, they're not combinations. And then there was another study in Europe where patients received doxycycline, clarithromycin combined with hydroxychloroquine, which is not recommended for Lyme disease, or placebo. And they basically found the same thing, that the score, they used a RAND SF36 physical functioning score, and they found that it did not differ between the groups, the placebo and the treatment groups. So then there's another study by Krupp et al., which was a randomized double-masked placebo-controlled trial with 55 patients who had persistent severe fatigue at least 6 months or more, and they received 28 days of IV ceftriaxone or placebo. And they did see an association with improvement in fatigue, but not with cognitive function in this group of patients. And then Dr. Fallon at Columbia has done studies showing that he could see an increase in or improvement in patients who had more severe fatigue, pain, and impaired physical functioning at 12 weeks, but this was not sustained. So they saw an improvement, but it wasn't sustained. So in both the Krupp and Fallon studies, fatigue severity was significantly reduced with repeated antibiotic therapy. Pain was reduced as well, but cognitive function was not affected as dramatically. So this was reviewed, and with a biostatistical review revealed that retreatment can be beneficial. Primary outcomes reported as statistically insignificant were likely underpowered. And the authors stated that the positive treatment effects of ceftriaxone are encouraging and consistent with continued infection, which is a hypothesis deserving additional study. We can do this in non-human primates, but it's definitely hard to detect persistent infection in living humans. So there has been a study on combination therapy, and this came out of France recently. And these patients were had severe neurological disease. Many of them were impaired for mobility. They had limb paralysis and high disability scores. Many of them had co-infections, and they had disease for over 6 months, including fatigue, pain, and subjective cognitive deficits. The treatment was various number of cycles of IV ceftriaxone. They were also some treated with oral azithromycin, doxycycline, or azithromycin, doxycycline, and rifampin. So there is combination therapy utilized here. And what they found was that 7 of the 10 patients showed complete remission. And there are some very striking videos of patients who were paralyzed up and walking normally after this treatment. And the mean of 4 ceftriaxone cycles. 3 experienced relapse, but 7 of the 9 borreliosis patients obtained complete remission. And so the caveat to this is that this is an observational study. It's not a clinical trial. So you can't determine the efficacy of a specific combination because it needs to be compared to the standard of care, which they did not do. And that's hard to do when you have severely disabled patients. So overall, the conclusions are that animal studies, I didn't talk about dogs, but or mice too much, but studies in mice, dogs, and primates demonstrate the persistence of Borrelia infection following monotherapy with doxycycline, amoxicillin, ceftriaxone, and tigecycline. Human clinical trials demonstrate that single antibiotic therapy beyond the standard 14 to 28 days can provide improvement, but often it's not sustained. Combination therapy, at least in mice, demonstrates eradication of the spirochetes, whereas monotherapy clearly did not. We've seen observational studies in humans that show sustained benefit with combination therapy. And I believe very strongly that randomized controlled trials of combination therapy in patients with post-treatment Lyme disease need to be performed. So the gold standard diagnostic test detects antibodies to Borrelia burgdorferi, but we've seen that changes in the response to infection over time can vary significantly. So we need to think about that when we're developing a diagnostic test. The most common recommended antibiotics are microbiostatics, so they rely on a good immune response, and not all patients have a good immune response. Some more research is definitely needed, but several studies indicate that the humoral response to infection or the antibody response to infection correlates with a good treatment outcome. And we know that Borrelia can manipulate the antibody response, and what controls this in each individual patient needs to be explored further. So with that, I would like to conclude. I'd like to thank the members of my laboratory who do all the work, and certainly the funders of this research. And with that, I may have some time for questions.
Thank you so much, Dr. Embers. That was a great presentation. I believe there is a question in the chat, but before I have Jan read that to you, I am going to launch a very short 4-question evaluation survey. If everyone can please answer these questions. And also, I do have a quick link that I'm going to drop into the chat as well. It's a survey link. All of your answers are anonymous and they help us meet our funding requirements. For anyone on the call who would like CME credit, this red cap link in that is coming your way is required. All right, so I will turn it over to Jan to direct any questions. Thank you so much.